Thank you very much, Nasir, for giving me this prestigious oration. And I hope during the course of my presentation, I can reproduce some of the pioneering spirit of Professor N. Madan Gopalan, who's truly a pioneer in gastroenterology. So the success of living donor liver transplantation in India is the topic I chose to speak. But more I looked at the topic, I realized that there's a flip side of it as well. As an operation, it is hugely successful, but we do not have a robust program. Large number of recipients are foreigners, and I thought perhaps I should focus more on challenges in delivering a liver transplant service in India. And what are these challenges? The challenges are numerous: human resource, nurses attrition, mainly a living donor program, no national health service as yet, absence of cadaveric organs, financial burden, and yet even now after so many years we do not know who's the right patient for the transplant. And of course, ensuring long-term follow-up in a country which does not have a national health service is a big challenge. So there is no present without the past, and we must go back into the past. 1994, the Human Transplant Act was passed through the Parliament. Brainstem diagnosis became a reality. Yet, brainstem diagnosis is mainly in transplant hospitals, linking the two, which has been kind of come in the way of, of cadaveric organ donation. The first successful program in India was established in Sir Gangaram Hospital. Now there are over 200 liver transplant centers licensed. Over 50% of transplants are in Delhi NCR region, but the bulk of centers are in Maharashtra, Tamil Nadu, Andhra Pradesh, Telangana, and Karnataka. So coming to now, and we now do over 4,000 liver transplants annually. Most of it, as you can see in this diagram, are living, and a small proportion is disease donation. Our own journey, we had a sort of start in 2000, but in those days, operation was in fits and starts, not many. But from 2006, we've been sort of regularly, the numbers been rising. And 2013, we were the first transplant center in India to complete 300 transplants in one calendar year. And later, in 2022, we crossed 400 transplants in one single year. In spite of this, there is no room for complacency. We are number 3 in total transplants per year, as you can see in this graph, but we have one of the lowest rates of transplant per million population, one of the lowest cadaveric donation rates, and one senior hepatologist told me that liver transplantation is a trial by fire. And every now and then there is an article suggesting that there is foul play in transplantation. But in spite of all that, we often have a very happy moment, and this is a young girl presented to us almost 20 years ago with fulminant Wilson's liver failure, and we did a transplant, and she is now off immunosuppression, completely rehabilitated. So there's a challenge in liver transplant surgery, which is by nature is in a sick patient, unpredictable post-operative events, and the nature of the surgery makes that normal healing is impaired. And LDLT also puts another individual at risk, and success can turn into failure overnight. There's a challenge in human resource. There needs to be a person who is, I think, preferably should not be a surgeon. Unfortunately, most of the programs in this country are headed by a surgeon. But he must be well versed in critical care, preoperative management of chronic liver disease, ICU management of critically ill patients with cirrhosis, infection control, immunology, and also be familiar with surgical steps and complications, long-term management of transplanted patients. Teams break up, nurses don't stay for long. And I hope that in memory of Professor N. Madan Gopalan, who emphasized the importance of working closely with other specialties to ensure success. So the challenges are enormous, but we have many favorable factors. There's a large pool of well-trained surgeons, salaries of nursing and paramedical staffs are low, therefore costs are low, infrastructure requirements are minimal, graft quality is excellent, donor safety is safe if we follow the right criteria. Now, when I come to challenge in selecting the right patient, The patient with cirrhosis unwilling for a transplant. He's heard so many horror stories. Lack of cadaveric organs. The mysteries of hepatology not clear to HPV surgeons who drive these programs. Most transplants in private sector, which is often looked at as a money-making exercise. Donation in government hospital not go to a private hospital, even though the costs are same. So who do you transplant? If they're too sick or too well, both the conditions you cannot transplant. Sarcopenia, frailty, infection, impact on outcome, and there is no reliable index to predict futility. Of course, there's general agreement that the 1 year survival should exceed operative mortality of the center. The US uses the MEL score, the UK uses the UKL score, and what do? We have very little cadaveric organs. Most patients are ACLF3 if we follow the EASL definition. Many critically ill patients are managed with the hope that their general condition will improve so that they can have a transplant. Organ allocation is to a hospital rather than named allocation. Far more discussion in futility rather than utility. And interestingly, if you look at outcome of Indian patients versus foreigners, most programs will tell you this, that the outcomes in foreigners far better. 3% 1 year mortality, whereas 11 to 15% in the Indian patients. And this is mainly from delayed timing for transplant, poor nutritional status, mostly female donors with small livers. That's a data over the years, and 1 year survival sort of has been over 85%. And last year we seem to be doing well, but maybe it's too early to comment on 1 year survival from last year's data. Which brings me to another pressing need of the moment, which is transplant in ACLF3. Most reports in living donor liver transplantation are in those patients who have recovered and then went on to have a transplant. What about transplant for those in ACLF3 who do not improve? Published data from Madan Medical Center suggests that even within comparable MEL scores, outcome in ACLF3 is poor. Very little Indian data. There's one from AIG, which ACLF2, approximately 80% survival, and our own data of 70% survival in ACLF3. I think it's time now, till we agree on a uniform listing criteria or selection criteria, that we look at UNOS status 2B and select patients accordingly for transplantation. Quite often, sepsis and liver transplantation go hand in hand. Spontaneous bacterial peritonitis obviously needs aggressive treatment. Chest infiltrates are often not pneumonia in ACLF, and one need not wait for complete resolution of cellulitis, infected hematomas, tuberculosis prior to transplantation. The contraindication for transplant is septicemia, sustained AKI, encephalopathy, high FiO2, refractory hypertension, high lactate, GI mucosal bleed. Sepsis is perhaps easier to treat with good liver function and absence of technical complications. The ICU care for a transplant unit is slightly different. These rooms should be designed like a OR with sort of own air handling units. These HEPA filters probably need to be changed regularly. You merge them into one area so the nurses old nurses and new nurses can work together and learn from each other. And importantly, relatives we find are very important in care of these patients. Rejection in living donor liver transplantation is not a devastating diagnosis, and most of us who had sort of DDLT background relied a lot on liver biopsy, but a liver biopsy in small grafts in LDLT is not an easy job. You can cause excessive bleeding. Transjugular liver biopsy, of course, quite often will help take the biopsy, measure pressures, and general adjustment of immunosuppressive dose may be sufficient in these patients. Bedside assessment and management of sort of the ERAS protocol, which is very popular in surgical circles now: chest physiotherapy, early mobilization, prompt drain removal, adequate analgesia, fluid balance, weight measurement. As you can see, this has a nice weighing machine at the end of the bed, nutrition, and you get good outcome. Common sense and history taking, in spite of advanced technology, still works. And I remember a person was referred to me for tricuspid valve repair or replacement and liver transplantation. We found that his PA pressure had risen enormously because of albumin infusion. In spite of the raised creatinine, we were able to sort of get his pressures down with furosemide and then transplant him successfully. There is a living donor liver transplant goes through, in every center will go through a learning phase, Then there's a phase of innovation where you find solutions for problems that you faced. And finally, you have a phase of consolidation. So, in the learning phase, the team is new, they're less willing to take on challenges, reliance on investigation, costs tend to be more, morbidity and mortality will affect morale. Then, in the innovative stage, you eliminate vascular complications, you learn how to deal with your problems, ability to deal with biliary complications, small for size syndrome, and then you obviously evolve now to minimally invasive and recipient surgery. And then in the consolidation phase, and that is something that we all teams where the hepatologist, anesthetist, intensivist starts working in tandem, patient to patient referral has started, there's willingness to take on difficult cases, and you have reproducible results. To just take you through our phase, initially we had the learning phase where we had a background based on disease donor liver transplantation in UK, and we didn't realize at that time that the two operations were very different, and outflow was a big issue. Ischemic congested segments had greater impact on overall graft function rather than on the volume, on the segment that they were involved with. Innovation, we learned that the middle hepatic vein needed to be dealt with in order to have good outcome, because as you know, liver has two lobes but three major veins. Because I had biliary issues, and then we learned that bile leaks were not difficult to manage, it could be just managed by drainage rather than by early ERCP, or if you really needed to do early hepatic osteogenostomy. We published some important papers on small for size syndrome where the graft weight was more important than the volume once 650 grams was reached. Then we understood that every single vein of the liver must be drained in order to have good outcome, and we showed in this a paper that the orthotopic position of the liver must be maintained to have good outcome. Size matching in small babies is an innovative technique. We introduced this medial reduction in children so that small babies less than 6 kgs could have a transplant. We also had enormous support from our interventional radiologists, and this is one case from Calcutta, an uneventful transplant. Next day, the middle hepatic vein was thrombosed, and the IR person opened it up. The patient recovered and went home. Hepatic artery thrombosis, this is again help from our IR team. They opened up this vessel beautifully post-transplant. Person did well. In the beginning, we had shortage of venous graft because cadaveric donations are infrequent. So we developed this innovative technique of getting from the explanted liver a complete sort of portal vein, and we published this in liver transplantation. There's a lot of interaction between tacrolimus and ecosprin, and this is something that we learned initially when neurological complications would happen. If they were on ecosprin, they would end up with major bleed. And we actually did a transplant from a person who had a disease donor liver transplantation from a cadaveric organ, then was an aspirin, had bled again, and then we were successfully able to use that organ in another recipient. Hyponatremia used to be a big problem, and we lost many patients trying to correct the hyponatremia pre-transplant. We learned that it's possible to do this transplantation in hyponatremia provided you did not allow sodium fluxes in the operative and perioperative phase. Reducing costs, I think in in the year 2000, the cost of liver transplantation 20 lakhs, and this is 2024, and the cost is still 20 lakhs, in spite of costs going up in every known sort of thing in our life. So we were the first group to show that liver transplantation for hepatitis B was possible without expensive immunoglobulins. We also showed in associate with our colleagues in Pakistan that preservative solution was not needed for living donor liver transplantation. We published this into 2022, and we showed also that routine CMV prophylaxis was not necessary. And in many ways, we look at every day how we can reduce costs. And another way where we reduce costs is minimally invasive donor hepatectomy, where we combine robotic, laparoscopic, and open technique and small midline incision so that expensive staplers are not needed. Then we come to the final phase, the consolidation phase, which is really, I'm quite happy that we've reached this stage. Hepatologists, anesthetists, intensive care, they work in tandem. Patients to patient referral has started. Willingness to take difficult cases and with reproducible results. So I think I'm going to sort of look at how things should be in the future in a liver unit. The hepatologists see and manage preoperative patients, gain skills in understanding surgical tenets, almost become a surgeon without attending the OR. The anesthetist works in tandem with the team, anticipates difficulty, and warns surgeons of likely mishap, and the intensivity learns to manage patients after finding out events in OR. And of course, as you keep doing, growth of the program will happen from patient to patient referral. So one of the important areas that we worked closely is that liver transplantation versus alone versus combined liver and kidney transplantation. We've shown that liver transplantation in renal failure is possible without doing a simultaneous liver kidney transplantation. We published this in Transplant Proceedings. We also published the first case, index case, for living donor liver transplantation for complete portal vein thrombosis. And also, we worked hard on overcoming shortage of organs. So we have one of the largest series of domino transplants, 13 cases. Paired exchange liver transplant, where we have over 34 cases that we published in 22. And we've now done over 160 ABOI living donor liver transplantation. And a trainee from the armed forces written a beautiful paper in liver transplantation, that outcome of ABOI, living donor liver transplant, is better in biologically related donors. Used older donors, and we used sort of posterior sector grafts, which is half of right lobe grafts in cases where the remnant is slow. So there's a paper from liver transplantation where on ABOI incompatible liver transplantation, we've reached good results with ABOI. Now, one of the areas that we see often is HCC, and I think the hepatologist should be treating HCC. It's not the oncologist who should be doing this. Treatment is determined by the stage of the cirrhosis, and they're best suited for multimodality management, and impossible for the oncologist to assess liver reserve and predict outcome after chemo, radio, and immunotherapy. And similarly, the interventional radiologist should not decide treatment for HCC. That's, of course, my personal opinion. Multimodality treatment of unresectable HCC works, and as you can see, a large tumor into the portal vein. We did arterial ligation, radiotherapy, and sorafenib, and 12 years on, after transplantation, recurrence-free. So what do we see in the future? I think the division between hepatology, transplant hepatology will blur. The liver specialists will evolve into interventional, which hepatologists in charge of sort of doing himself maybe, TACE, HPPG, local ablative therapy, liver support devices, ERCP. There will be an intensive care hepatologist who manages cirrhotic patients with organ failure, ALF, and small foci syndrome, and a transplant sort of hepatologist listing, delisting patients, allocating organs, predicting post-operative events, managing immunosuppression, managing infective complications, and looking after them in the long term. And the surgeons, I think, should go back to the operating room. They should not be burdened with managing patients in the perioperative period, except for post-operative bleeding, which of course we have to take them back to theatre. And I think the future generation surgeons burn out if they involve themselves in all aspects. And it's quite possible, as I see it, that more and more transplants will be done. And if xenotransplantation takes on, and we heard very exciting news of all this nowadays, that there will be huge spurt in transplant numbers. There's also going to be a big increase in non-heart beating donation. I think the donation from brain dead donors have probably peaked. The major increase may happen only in a complete overhaul of health system, and I don't think that any more numbers are going to increase markedly now. Donation after circulatory determination of death remains completely untapped in our country. And as I say that the natural birth and natural death in the city of Delhi has finished. Everybody dies in hospital, and therefore there is a huge untapped source. Newer technologies with machine perfusion and normothermic regional perfusion will make this possible. And come to my final slide, which is I feel truly honored and delighted to have given this oration, and I hope this oration inspires our younger colleagues to take up this specialty in greater numbers, and I'm hoping that more and more government hospitals should engage in liver transplantation, and hopefully the number of transplants should exceed the mere 4,000, of which the great majority in foreigners that we do, to about 25,000, which is what is the estimated need for liver transplantation in the country. And of course, this should not come at the cost of donor safety. Thank you very much for your attention.